Welcome to the Deep Dive. We're the show that takes complex research, digs through it, and gives you the core knowledge you can use right away. Today we're tackling something, well, pretty fundamental. It's this deep human desire not just to live longer, but really to live better.
That's exactly it. For such a long time, all the talk was just about lifespan, how many birthdays you get. But there's been a really critical shift, and you see it clearly in the sources we looked at. The focus now is moving towards health span.
Health span, meaning the years you spend, fully independent, able to do things, free from those really debilitating chronic illnesses.
Precisely, those functional years, the
Yeah.
quality years.
Okay, so we've gone through a whole stack of materials, scientific papers, demographic studies, some pretty intense policy reports to really explore the plan, the psychology, and the politics behind maximizing those healthy years.
And maybe a good place to start is what people actually want. There was this recent survey, pretty striking finding.
Yeah, get this. A massive 94% of older adults said they prioritize maintaining their quality of life over just living as long as possible. 94%.
But that priority runs smack into the reality on the ground. The U.S. spends, more per person on healthcare than any other country.
Highest spending.
Yet we rank 50th in lifespan. And even more alarmingly, 68th in health span globally. There's this huge disconnect.
Wow, 68th. Okay.
So our mission today is really to break down the science, the metrics that matter, and the psychological factors that could help bridge that, frankly, yawning gap.
All right, let's dive into the science first. There's this key concept, a specific goal, really, the compression of morbidity, COM, for sure. COM. It was proposed way back in 1980 by Dr. James F. Rice, and it was a really powerful counterargument to the pessimism back then.
What pessimism?
Well, there was this idea, they called it the failures to success paradigm. Basically, it said, great, we're extending life, but all we're doing is adding, 10 extra years of sickness and dependency at the end. Grim stuff. Okay, yeah, that does sound pretty bleak. So COM is the alternative.
Exactly. It's the strategy to avoid that. COM requires that the age when chronic illness starts gets pushed back faster than the age of death gets pushed back.
So you're literally squeezing that period of illness,
Yeah.
compressing it into a shorter window right near the end.
That's the idea. You avoid that long, slow decline. The goal isn't just delaying death. It's delaying illness even more than you delay death. That's the critical part.
I get the distinction, because the alternative is...
The alternative is extended morbidity, just a longer time suffering. But the good news, and this is where the research comes in, the longitudinal studies show COM isn't just some nice theory. It seems to be achievable.
Okay, so let's see the proof, the numbers, because that's what really makes it click, right?
Absolutely. Let's take the UPenn study. It followed people for 21 years. They looked at a low-risk group. These are people who managed to avoid the big risk factors, like smoking, obesity, not exercising.
Okay, the good behavior group.
Right. And this group, they postponed the onset of physical disability by a really stunning 8.3 years.
8.3 years. Wow, that's huge. 8 more years of being fully functional. But what about their total lifespan? How much longer did they live overall?
That's the key comparison. They only postponed death by about 3.6 to 3.9 years.
Okay, so much less.
Much less. That's the compression right there in the numbers. The benefit to quality of life, those extra healthy years, was more than double the benefit to just the quantity, the number of years lived.
That's actually profound. It means focusing on healthy habits buys you way more quality time than it necessarily buys you extra calendar years. It pushes that disability wall back much further than the mortality wall.
You got it. And the runner study, also over 21 years, showed something very similar. People who were dedicated runners, they delayed hitting a certain level of disability by 12 years.
12 years.
12 years, compared to, again, a much smaller delay in death, less than double that 12 years. So this is really solid evidence that lifestyle hits health span much harder than it hits lifespan.
Okay, so if CAM is the goal, and it works, how do we actually do it? The sources talk about 4 prevention strategies. Primordial, primary, secondary, tertiary. Sounds a bit technical. Can we unpack those?
Yeah, let's break it down. Think of them as 4 layers of defense kind of spread across your life. Primordial prevention is the very first line. It means stopping the risk factor from ever developing.
Like telling kids not to smoke.
It's even earlier than that, ideally. Think about public health policies like reducing the marketing of junk food to kids. The goal is to lower childhood obesity rates before those unhealthy habits even take root and become risk factors later on.
Got it. Preventing the risk from even showing up. Okay, so what's primary prevention then?
Primary is probably what most people think of as prevention. It's about reducing an existing risk factor. So if someone is sedentary or already smokes, primary prevention is the advice to start exercising or, to quit smoking. You're tackling the risk directly to stop the disease itself from starting.
Okay, makes sense. And if that doesn't work and the disease does start, say someone develops high blood pressure, then we move to secondary prevention.
Exactly right. Secondary prevention kicks in once the disease is present. The goal is to stop it from getting worse or coming back. Think regular cancer screenings to catch it early. Or giving medication after a first heart attack to prevent a second one. You're managing the disease.
Right, damage control, essentially. And the last one, tertiary prevention.
Tertiary is about managing the consequences, the morbid states that have already happened, usually later in life. These are interventions that are crucial for quality of life after something serious has occurred. Hip replacements after a fall, cataract surgery to get sight back, that kind of thing.
So you need all four working together, really, across a whole lifetime to maximize that compression.
Ideally, yes. It's a comprehensive approach.
Okay, one quick thing before we move on. We hear these, frankly, sometimes wild claims about living to 150, 200 years old. How does that fit with the COM data? What's the realistic maximum lifespan look like according to these sources?
Yeah, the data we reviewed is definitely more conservative than those very optimistic projections. While we can definitely improve the average health span, the calculations suggest the maximum average age at death we might reach is probably somewhere between 85 and 93 years.
Okay, so not 150.
Not based on this evidence. But the key thing for COM is it doesn't actually depend on hitting some magic lifespan number. It's all about the relative speed pushing back illness faster than death advances, whatever that final number is.
Okay, so we've covered the physical side, habits, prevention strategies. Now let's shift gears a bit, move inward to our psychology. There's this major study, the MIDUS longitudinal survey, followed people for 23 years.
That's right, MIDUS,
Yeah.
a really long-term look. And they were trying to figure out essentially what state of mind actually helps you live longer.
And they looked at two main things, right? Life satisfaction and purpose in life.
Two common ways to measure well-being. Life satisfaction is more of a snapshot, a cognitive thing. Overall, how happy are you with your life right now?
Okay. Contentment, maybe.
Yeah. Sort of, yeah. Whereas purpose in life is more about direction. Do you have goals? A sense of meaning? Are you engaged in things that matter to you over the long haul?
Right. So the study put these two head to head. Which one turned out to be a better predictor of who actually lived longer over those 23 years?
Well, the results were pretty clear-cut. Purpose in life emerged as the more robust predictor of longevity, of lower mortality risks.
More robust. So life satisfaction still mattered a bit.
It did initially when looked at on its own. But here's the critical finding. When the researchers factored in things like demographics, and especially when they controlled for how healthy people said they felt their self-rated physical health,
Oh, okay.
the predictive power of life satisfaction basically vanished. It didn't add much beyond just feeling physically okay.
Wow. Okay, that's a really important difference. So just feeling generally satisfied or comfortable isn't the key driver for longevity, but having goals, having that sense of direction, something driving you forward that actually adds years to your life.
That seems to be the implication, yes. Purpose appears to tap into some kind of deeper psychological resilience. When you have that sense of meaning, you stay engaged with life, even as physical problems might start creeping in with age.
You cope better. You stay active.
Exactly. You keep seeking out activities. You maintain social connections and roles. It's not passive contentment. It's an active engagement with living.
An active drive.
Precisely. And interestingly, the data showed this link between purpose and longevity was actually a bit stronger for the older participants in the study.
Really?
Yeah. Which suggests that finding, maintaining, or even strengthening that sense of purpose becomes increasingly important for health span as we age.
Okay. We have the science with COM. We have the psychology with purpose in life.
Yeah.
Now let's get into the tricky area, policy. Specifically, how health systems try to put a number on quality of life and longevity using something called QALYs. Quality Adjusted Life Years.
Right, QALYs. It's a metric used quite a bit, especially by organizations trying to figure out where to allocate limited healthcare resources. Think drug approvals, deciding which treatments offer the best value.
How does it work, basically?
Well, the calculation itself is pretty straightforward. It's arithmetic. You take someone's expected remaining lifespan in years, and you multiply it by a score representing the quality of those years.
So perfect health is a score of 1.
Yes. A year in perfect health equals 1 QALY. But if you have, say, chronic pain or some disability that reduces your functioning, your quality score might be lower, maybe zero point 0.8 or zero point 0.5.
So 10 years expected life at perfect health is 10 QALYs, but 10 years with a condition that gives you a zero point 0.5 score is only 5 QALYs.
That's the calculation. And then organizations use this to figure out cost-utility ratios, basically. How much does it cost to gain one QALY with a particular treatment? It helps them prioritize spending.
Sounds logical, maybe even fiscally responsible on the surface. But you said it's controversial.
Oh, intensely controversial. There's significant ethical opposition, and it's really important we cover this impartially.
Okay, what's the core ethical argument against using QALYs?
The main argument is that QALYs are inherently discriminatory, particularly against people already living with disabilities or chronic illnesses.
How so?
Because their starting quality score, the Q in QALY, is already lower than someone in perfect health. So even if a life-extending treatment works perfectly for them,
It generates fewer QALYs than the same treatment would for a healthy person, just because their baseline Q was lower to begin with.
Exactly. So the concern is, if you strictly follow a maximized QALYs gained per dollar spent rule, you could end up systematically deprioritizing treatments that benefit people who are already disabled or chronically ill.
So the system designed to maximize overall health gains could inadvertently undervalue the lives or the health improvements of people who aren't starting from perfect health.
That's the crux of the ethical objection. The National Council on Disability, the NCD, they actually issued findings stating that QALYs are, and I quote, discriminatory, or at least potentially discriminatory.
What were the specific worries?
The big worries were about, quote, coverage denials and loss of access for these groups. That using QALYs could lead to people with disabilities being denied necessary care that others would get.
Okay, that's a serious charge. Given these ethical concerns, how have policymakers in the U.S. responded?
Well, the response has been pretty significant in some key areas. Generally, U.S. federal law prohibits the Department of Health and Human Services, HHS, from using QALYs to decide on Medicare coverage or reimbursement.
So Medicare can't use it for those decisions.
Correct. And beyond the federal level, at least one state, Oklahoma, took action. They passed a law, effective late 2020, that explicitly bans state agencies from using that dollars per QL measure.
Interesting. So the debate is definitely active, pitting that efficiency argument against fundamental questions of equity and discrimination.
And it really highlights that tension, yes.
So this whole policy debate is happening while demographically things are shifting dramatically. The number of people 65 and older is just exploding, expected to go from around 56 million in 2020 to over 82 million by 2050.
A huge increase.
Huge. And yet, despite this massive wave, satisfaction with the healthcare system among older adults is, well, pretty low. Only about 11% give the U.S. system an A grade.
Yeah, that dissatisfaction isn't surprising when you look at some of the systemic issues that directly undermine Healthspan. One huge problem is the shortage of specialized care.
Geriatricians, you mean?
Exactly. The number of geriatricians actually dropped by 28% between 2000 and 2022.
Dropped. Well, the 65-plus population
Grew by 60%. You see the problem, that gap is just unsustainable.
Wow. And beyond just shortages, the type of care often feels fragmented, right? Treating one disease here, another there, not really looking at the whole person.
That's a major criticism, yes. The sources really point to a failure in providing personalized care. Get this, only 58% of older adults say their healthcare providers routinely ask them about what matters to them.
Less than 60%.
Right. And if the care plan isn't aligned with what the patient actually wants, their goals, their priorities, how can it possibly optimize their health span, their quality of life?
Good point. So to try and fix this, to bring the focus back to the whole person and what they need, the sources recommend something called the age-friendly care approach, using the 4Ms framework. We should definitely detail those MIMs.
Yes, the 4Ms. It's an evidence-based framework designed to improve care for older adults. The M's stand for matters, medications, mind, and mobility.
Okay, let's take them one by one. Matters. How is that different from just, asking about symptoms?
Matters is fundamental. It goes beyond just the medical chart. It's about truly understanding the individual's life goals, their health priorities, what they value most. Maybe it's being able to walk their grandchild down the aisle. Maybe it's staying mentally sharp. The entire care plan should be built around what matters to that specific person.
Okay, that directly tackles that personalization gap we talked about. What's the second M? Medications.
Hugely important for older adults. They often have multiple conditions, multiple doctors, and end up on a lot of different drugs, polypharmacy. So medications is about carefully managing all of those prescriptions.
To avoid bad interactions or side effects.
Exactly. Reviewing the full list, reducing harm, making sure the treatments aren't causing new problems like dizziness that leads to falls or confusion that just wreck quality of life. Deprescribing, when appropriate, is key here too.
Right. Okay, then mind.
Mind focuses squarely on cognitive and mental health. That means screening for and managing conditions like Alzheimer's and dementia, of course. But it also crucially includes mood depression, anxiety, which are incredibly common and have a huge impact on function and engagement.
Makes sense. And the final M, mobility. This seems to tie right back into that compression of morbidity idea, staying functional.
It absolutely does. Mobility is essential for independence. This M means providers need to actively assess how well the person moves, focus on preventing falls, maximize their physical function, maybe suggest environmental adaptations, anything to keep them safely active and mobile. Lose mobility and your health span plummets no matter how long you technically live. Hashtag tag outro.
So wrapping it all up, we've really covered the blueprint from several angles today. There's the scientific strategy calm, focusing on pushing back disability faster than death.
Right. Then the psychological fuel that active purpose in life being a stronger predictor than just feeling satisfied.
And finally, those tricky policy hurdles around QALYs, trying to balance value and ethics in healthcare spending.
And as we look forward with technology advancing, talk of slowing down aging, maybe even stopping it, the ethical questions just get bigger, don't they?
They really do.
So the final thought you want to leave you with today really centers on this issue of distributive justice. Think about it. If we develop really effective but expensive life extension technologies, maybe something that adds 20 truly healthy years, who gets access first?
Almost certainly the wealthiest people, the wealthiest countries.
Right, which could massively widen the already huge gaps we see in health and socioeconomic status around the world.
So maybe the most urgent moral task right now isn't necessarily chasing biological immortality for a select few, which might even be a dangerous illusion anyway.
Perhaps not. Perhaps the real imperative is tackling the enormous and, frankly, correctable disparities in both lifespan and health span that exist right now. We're talking about a 40-year difference in life expectancy between countries like Japan and, say, Zimbabwe. 40 years.
That's staggering.
It is. So maybe focusing on social action, on collective efforts towards greater equity in basic health, education, living conditions, maybe that is actually the most powerful strategy we have right now to extend healthy years for the largest number of people on the planet.